Good morning, everybody, or good evening, I should say. Good evening to all of you tonight. We appreciate having you join us tonight for our spring session of Cancer Connections. If you've not been here for Cancer Connections before, I am Diane Munch. I'm the leader of our professional practice team, and here at the Robert H. Lurie Comprehensive Cancer Center of Northwestern University. And we welcome you to this educational program that we provide for our patients on a quarterly basis. We are very excited tonight to bring you some topics related to education updates on cancer treatment. And thank you for joining us. We're excited to do this in a virtual setting and be able to reach as many people as are on our program tonight. A few extra shout outs here to our advocacy partners. I don't know if you were able to get onto our virtual resource fair, but we hope that you have a minute to learn about all the support that our advocacy partners provide to our cancer community, patients, families, loved ones, and significant others. And then again, thank you to all of our speakers tonight for sharing their time, talents, and expertise. We have wonderful professionals here at the Cancer Center. And a few housekeeping items. We want you to know that your video and your audio will be muted during the program to make this the program a little smoother and provide no other background noise. But if you do have any questions, we ask you to put those questions in the chat during the video or during the presentations. We will have a live question and answer session at the end of each presentation, and I'll be moderating the questions. So please put whatever comes to mind into the chat, and we'll keep track of those as we go along. If you have any technical issues during the program, please feel free to email cancer.northwestern.edu, and our technology consultants will try to help you as much as they can, and certainly put any issues you might be having into the chat. So that being said, I'm very pleased to introduce our first group of speakers. I have Taylor Drowne, Taylor Kujawa, and Claire Schumann. They are all pharmacists here at the Cancer Center at the Central Campus. They are pharmacy residents that are completing a hematology oncology pharmacy, working in both the inpatient and the outpatient setting. And during the day, to give you an idea of how involved they are in patient care, they help with management of supportive care issues. They provide education to patients regarding cancer therapies. They look for drug interactions. They're helping enter treatment plans, providing recommendations for dosing. They are a very, very important part of our cancer treatment team. And we are very excited today that they're going to bring some information to you about a topic that I'm sure you've heard before. We're going to talk a little bit about precision medicine. Taylor and Claire are going to present a presentation called Understanding Precision Medicine, and we do invite you to put questions for them in the chat, and we'll get to them as soon as their presentation is complete. So I'm going to jump off camera and invite Taylor to get started.
It's so nice to be here. Thank you so much for having us, and thank you to Diane for that lovely introduction. My name is Taylor Kujawa, and I'll be starting off the presentation. So like Diane said, we are very excited to present to you all today about precision medicine and some treatment options based on very specific patient factors that we're going to talk about today. And then like Diane said, please, if you have any questions, just go ahead and put those in the chat, and we would be happy to answer those at the end. As far as what we're going to talk about today, so we are going to talk a little bit about the development of cancer and the implications of genetic changes. We will define what is precision medicine, and we'll talk about the implications for cancer therapies. So what is it and why is it so important? We'll spend a little bit of time talking about the difference between chemotherapy, immunotherapy, monoclonal antibodies, and targeted therapy, which are probably some terms that you've heard thrown around, but it's important to kind of understand what each of those are and what the side effects are associated with them and how that they work. And then lastly, we'll look at the application of precision medicine. So we'll give you some examples for some specific cancers and kind of talk about what it looks like and what we're looking for in our testing and how that kind of translates to treatment options. So our first part is just going to be an introduction to cancer and kind of the diagnostics. So first we'll talk about how cancer develops. I think it's important to understand this because some of the precision medicine testing, and then we can also understand kind of how the medications work if we talk about this a little bit. And so I'll start by saying that genetic changes can be inherited. They can also arise from environmental exposures, and then they can also arise from errors that occur as cells are kind of growing and dividing. These cancer-causing genetic changes can kind of accumulate as a person gets older, and that's why older individuals are a little bit higher risk for developing cancer later in life. But I will note that younger people can also develop cancer, and that's because certain mutations can be driver mutations, and so a single mutation can lead to the development of cancer as well. And then most of these cancer-causing changes occur in these sections of the DNA that's called genes. And these genes tend to develop additional mutations in other genes, which then together can cause cells to become cancerous. And then what we have is cells that kind of grow uncontrollably and they can spread to surrounding tissues. This is kind of a schematic of what I just talked about. So on the top left hand of the diagram, you can see that shows normal genes that are kind of regulating the cell growth. So those genes and that squiggly line thing, that's going to be the DNA. Those are going to be genes that are telling your cells when to grow and when to stop growing. When we have mutations in the cancer cell, like in the bottom left, then we have uncontrolled kind of cell growth and division of those cells. And you can see that in the picture on the right-hand side too. So on the normal cell side, you can see that cell division stops. And then on the side that has the cancer cells, cell division just kind of continues. And that's what leads to this uncontrolled growth of the cancer cells. These are a couple of terms that I'm sure you guys have maybe heard, so we'll just go ahead and define them. Germline and somatic mutations are often discussed when we're talking about what type of mutation it is. So a germline mutation is going to be something that is inherited and it's found in all cells. A somatic mutation is something that is not inherited and it's found only within the tumor cells. And so you can see in the figure on the left, the mutation develops before kind of the person is born and kind of in utero. And then on the right side of the picture, that mutation happens afterwards. And that's only going to be found within certain cells versus the germline mutation is found in all cells. The next thing that I'll define is an oncogene and a tumor suppressor gene. So you guys may have heard these terms as well. So an oncogene is going to be a gene that's involved in normal cell growth. And once that's turned on, it can cause uncontrolled growth. And it can be turned on by DNA changes and mutations. A tumor suppressor gene is kind of the opposite. So this is going to be a gene that a DNA change is going to cause inactivation of these genes, which then leads to uncontrolled cancer cell growth. So these are usually going to be suppressing growth, and the oncogene is going to be causing growth. And so when we have mutations, we can have the development of cancer. So what is precision medicine exactly? So a basic definition of it is this is an approach that promotes selection of treatments that are most likely to help patients based on a genetic understanding of their disease. And so instead of giving all patients the same medication or the same therapy, we're going to be giving patients a medication that is kind of personalized to their disease state and their patient characteristics. So another way that I like to think about this is that we're choosing the best therapy based on specific features for the specific patient. Some other terms that you may have heard are prognostic versus predictive factors. A prognostic factor is going to be a measurement that's associated with a clinical outcome in the absence of therapy or with patients that are getting standard therapy. And so this is going to be things like age, the patients have metastases, which is cancer that has spread to other parts of the body. How much has the tumor invaded the body? And then genes can also be prognostic. So some genes are associated with a better prognosis than other genes. And then a predictive factor is going to be a measurement that's associated with a response or a lack of response to a particular therapy. And we'll talk about these when we go through our examples, but these are going to be some genes that are associated with specific cancers. And for a lot of those specific genes, we have medications that can kind of target that. And I will note too that not all mutations are considered driver mutations, and then not all mutations have implications for cancer prognosis or for treatment. Some mutations are just there and they don't really give us a lot of information or change our treatment decisions. I'll talk about the difference between tissue biopsy and liquid biopsy as well. So a tissue biopsy is often going to be preferred, and this is going to be what's used at the baseline kind of for diagnosis. So we'll talk a little bit about liquid biopsies because I think they're becoming more popular, but I do want to make it clear that these are not going to replace tissue biopsies. They can give us some more information in certain circumstances, and we'll talk about what those circumstances are. So a liquid biopsy is going to be a blood sample, and we're going to be looking for circulating DNA from various sources. And this is also going to pick up any DNA that's shed from the tumor. And so it's just a blood draw. Some of the advantages are that it's not very invasive. So it's just like getting your blood drawn versus some of our biopsies can be a little bit more invasive. And then this can also help to predict resistance to certain therapies. And then it can also help us to direct therapy when additional sampling is unavailable or we can't get it. We would use this if, like I said, we can't get an adequate sample or we can't do a tissue biopsy. And then we also use it to predict resistance to medications. Some of the limitations, though, it's not 100% accurate all the time. So if you have a negative, that's usually correct, but sometimes there can be some confusing results with this. And so that's why we kind of use the tissue biopsy as our gold standard. That's what we're going to be using at baseline for diagnosis. And then liquid biopsy also cannot assess everything. So it can't tell us the type of cells that are there. And then it also can't tell us about PD-L1 status, which we'll talk about a little bit more when we talk about immunotherapy. And then the last thing we'll talk about for this introduction section is going to be next generation sequencing. And so this is really the test that's done that's going to help us to identify those genes. And so this is used at many different academic medical centers. We use these to guide our treatment decisions. And this is going to be what's telling us what genes are there and helping us to determine what medications might be most helpful. And this is going to be useful in most types of cancer. There are still some challenges that remain with it. It is kind of expensive. It's sometimes unknown when would be the perfect time to do this. But I would say for the most part here, we're doing this at diagnosis. We're going to be looking for those targetable mutations that we have medications that we can use. And then we also may be using it if the disease is getting worse so that we can evaluate for any additional mutations that may have popped up or any changes in mutations. Okay, so with that introduction, I will turn it over to Taylor Drowne to talk about different treatment types.
Hi, everyone. My name is Taylor Drowne, so I will go over the different treatment types today. So we have a few different options. There's chemotherapy versus immunotherapy versus monoclonal antibodies and targeted agents. So how does chemotherapy work? So cancer cells grow and multiply very quickly, and our normal healthy cells know to stop growing and reproducing when they touch other cells in our bodies. And RNA and DNA in cancer cells tell these cells to keep growing, so they do not know when to stop growing. And then chemotherapy damages the RNA or DNA in the cancer cells and then stops it from multiplying. So that's how it works. Chemotherapy can be given a few different ways for different patients. It can be given orally through the vein over a few minutes, or can be given through a few days. And it can be a short injection, or it can be given directly into a body cavity. So as far as chemotherapy and explaining what a regimen is and what a cycle is, so both really depend on the type of cancer that the patient has. A regimen is a combination of chemotherapies that work well together, however. So they are often given nicknames based on which chemotherapies are used in them. So for example, on the top right, we have R-CHOP, and this is rituximab, cyclophosphamide, doxorubicin, vincristine, and prednisone. So it's usually sometimes whatever the chemotherapy begins with, and I'm putting those all together. A cycle is a block of time in which the regimen is given. So each regimen can have a different cycle time. It really just depends on the regimen. And as you know, there are a bunch of different regimens. So if, for example, we've got R-CHOP and it's a 21-day cycle. So that first cycle would have a couple of those chemotherapies on day 1. And then day 1 through 5 has prednisone. And then days 6 through 21, there's no active treatment. And then it would start again on day 1 after that, and it would be cycle 2, just as an example. As far as chemotherapy and the common side effects and how they're managed, so I just want to point out that the side effects really depend on the regimen and doses used. So this is different for all patients and all regimens. So one thing could be very variable for one patient and compared to another patient. So some of these common side effects, though, are hair loss or hair thinning, and this usually gets better after stopping the chemotherapy. Mouth sores are also another common side effect, which we refer to as mucositis. There can also be nausea, vomiting, and loss of appetite. We use pre-medications to help prevent the nausea and vomiting, and then usually patients will go home on medications to help with this if they're having it at home as well. It can cause diarrhea or constipation. And then chemotherapy can also cause decreased blood counts. So this could be a decrease in your white blood cells, which help you fight infection, a decrease in your platelets, which just help your blood clump, or a decrease in red blood cells, which help oxygenate your blood. So different things can happen to different patients. It can also cause numbness or tingling in fingers or toes, known as peripheral neuropathy, or it could cause fatigue. And then as far as immunotherapy and how this works, so your own immune system in your body, you have your own immune cells that ignore the body's normal cells. And immune cells recognize and kill harmful cells, such as those cancer cells. And your cancer cells are trying to avoid being attacked by the body's immune cells. And then there's such a thing called checkpoint inhibitors that stops the cancer cell from its efforts to avoid being attacked by the immune cell. So this is just a picture of how all of that works. As far as immunotherapy and the common side effects that can occur, this happens because some people's immune cells can react to the checkpoint inhibitors by damaging their normal cells. So your immune system is being amped up, and this can cause inflammation really in any organ system in your body. Some of the more common ones are a hormone imbalance, and this can be seen at any time in therapy. Another common one would be skin problems, such as a rash, and it can be itchy. And then there's also something called colitis, which could be inflammation of your GI system, and this can cause diarrhea. These are some of the main ones, but really immunotherapy can cause inflammation in any organ system, and this doesn't happen to everyone, but just some patients. And they're often referred to as itises. So there's an itis at the end of whatever immune organ system that's being affected. As far as how it's treated when you do have these side effects to immunotherapy, there's usually supportive care that we can use, such as steroids that calm down the immune system. And then side effects are really treated differently depending on how severe they are and what organ they're affecting. So we usually can just treat the symptoms, or if it's a little bit worse than that, we would use steroids. And then sometimes we need to stop the immunotherapy as well until patients get better, and then we can think about resuming it. As far as monoclonal antibodies and how they work, so these are proteins made in the lab, and they bind to specific targets on the body, such as an antigen on a cancer cell. So these block cancer cells that need to grow, or they can flag cancer cells, or they can deliver harmful substances to these cancer cells. There's a few different examples. So Herceptin or trastuzumab can just bind to the molecule that certain patients have, and it keeps it from sending signaling that these cancer cells need to grow. Bevacizumab blocks a certain protein on the molecule, which promotes growth of blood vessels that support tumor growth, and we inhibit this. And then pembrolizumab can attach to immune checkpoints like we talked about earlier to promote cell death on the cancer cells by the immune cells. As far as different side effects for these, so infusion reactions can be a little bit more common with these, or flu-like signs and symptoms, because this could be chills, fever, fatigue, muscle aches, or pains. Some examples of specific ones, so angiogenesis inhibitors can cause bleeding, blood clots, high blood pressure, or impaired wound healing. So it just makes it a little bit harder for any wounds to heal. And then there's something called HER2-directed therapies, and these can have a risk for heart damage, and that's usually why patients will undergo this imaging of the heart, and then they'll do that periodically just to make sure that they're doing okay. Can also cause diarrhea. And then we also have some oral agents. So these are more of that targeted therapy. And I just want to point out that while some of these cancers can be treated through oral agents, it really puts the pressure on the patient to make sure that they're taking these medications on time, and that they're taking them every day, and that they're really being compliant with these medications. Some of the different ones are hormonal agents. So some tumors respond to hormones and they need hormones to grow. So some of these agents block or alter these. An example is tamoxifen, which is anti-estrogen, and it just stops the body from accessing this, or anastrozole, which just decreases the amount of estrogen in the body. There's also tyrosine kinase inhibitors, and these block chemical messages to stop cancer cells from growing. So I won't really necessarily go over all of these examples, but it's just important to know that they usually turn off downstream signaling to stop tumor growth, or they block it somehow. And there's also PARP inhibitors. So these are important for patients with a BRCA mutation, which some of you may have heard that term before. And this is just important because PARP can stop from the repairing of the DNA damage to kill the cancer cell. There's also an example of venetoclax, and this can just inhibit B-cell lymphoma 2, which is just a protein found on some cancer cells. As far as some of the common side effects and how they're managed, so for hormonal agents, patients can have hot flashes, and it's just important that they avoid any triggers such as hot drinks, can have muscle or joint pain, can cause nausea, can cause osteoporosis, so we usually recommend vitamin D and calcium, and then can increase risk of endometrial cancer, but this is a very small risk. Tyrosine kinase inhibitors can cause fatigue, diarrhea, which we usually recommend Imodium for, which is over the counter, can cause nausea, mouth sores, higher blood pressure, a rash, or muscle pain. The PARP inhibitors, kind of the same thing. So fatigue, nausea can cause low blood counts, infections, or muscle pain. And then venetoclax can cause something where it causes your tumor cells to burst. And really to avoid this, we do lab monitoring and make sure patients are well hydrated. Can also cause low blood counts, diarrhea, infections, or fatigue. Okay, so that was kind of the main different agents that we use. And now I will pass it over to Claire.
Hi, everybody. So now that we have given you a background on precision medicine and some of the types of medications that exist, let's tie it all together. So why does precision, also called personalized medicine, matter? So overall, the data that we have that exists really shows that personalized medicine leads to better outcomes for our patients. So you can see here in this example at the bottom, the bar graphs with the results that show that the results are really much better for patients across the board. So that left-hand bar graph is looking at response rates for patients, so how well they respond to their personalized therapy. The middle graph is looking at the median amount of time without progression of their disease. And then that last graph is showing overall survival and how personalized medicine extends our patients' lives, which is really exciting. So let's go into a few examples, tying it all together. And I do just want to point out that these examples are not all inclusive. And as mentioned earlier, each patient's cancer is unique and different in their own ways. And so while these examples are meant to help bring our concepts together, they are by no means all inclusive or all encompassing. So the first example that we have is non-small cell lung cancer. So as you can see here in this graphic, it's really showing how this type of cancer has many different subtypes and different things that we're looking for. So the diagnosis and the tests that are done to determine that specific disease type has really evolved. So starting at the left, we have lung cancer, which is then divided into two different kinds. And for the purposes of this example, we'll talk about non-small cell lung cancer. From there, we look at what the cells look like and what type of what we call histology the cancer is. And so that would mean maybe it's a squamous cell or a non-squamous, also called adenocarcinoma, depending on the patient. Next, we would also look at the molecular pathology. So what I mean by that are the various mutations, some of which we've talked about already. If the cancer type has a specific mutation that we can then target. And then lastly, the last thing we would look for in non-small cell lung cancer specifically would be something that we call PD-L1. And it's something that's expressed on the cells, and we look at the percentage cutoff to see how many cells have that expression in order to determine if we can use certain medications for that target. So this pie graph has a lot going on, but the point of it is really to show that a lot of patients with non-small cell lung cancer have what we called earlier a driver mutation. So something that's driving that cancer growth and that we want to target to help prevent future growth. So as you can see, there are many, many different types of mutations here, especially in non-small cell lung cancer, all with different therapies that we could consider using. And as you can see, the three biggest ones would be our EGFR mutations, our KRAS mutations, and then an unknown driver mutation. So how does this impact the treatment decision? We have our initial diagnosis, and then like I said, we go through molecular profiling and look at that PD-L1 percentage. And then ultimately, if a targetable mutation is present, we will do what we can to target that. So we will match that with targeted therapy, with some of those mutations being listed on the right-hand side. And then if there's no targetable alteration, that's when we look at the PD-L1 expression. And depending on how high that percentage is, that determines what we use for therapy as well. Our second example is breast cancer. So things that we're typically testing for in breast cancer. The first one is hormone receptors. So that includes estrogen receptors or progesterone receptors. You may commonly hear this referred to as ER or PR positive or both. The way that that is determined is if it is positive on more than 1% of the tumor cells. The second thing we'll look for is what we mentioned earlier in the presentation called HER2. So this is an oncogene that's typically expressed at low levels in the breast tissue, but when it's expressed in breast cancer, it leads to abnormal growth of the cells, so an overgrowth of the cancer cells. And this one occurs in about 20 to 30% of breast cancer. How this impacts treatment decision specifically in breast cancer, there are certain therapies that we mentioned earlier as well, some of which that can target those certain receptors. So looking at hormonal therapy with agents like letrozole or anastrozole or tamoxifen, as well as our group of medications called kinase inhibitors. So those will be determined based on the patient-specific factors and preferences as well. The second one would be HER2 targeted therapy that we mentioned, and those include trastuzumab, pertuzumab, and then in HER2 Kadcyla, as well as some oral agents, and then the most recent one with margetuximab. So per the guidelines and what we do as pharmacists with the team, we talk about what mutations or what receptors are there, and we determine if any of these therapies could be utilized. And then of course, we bring that to you as the patients and we determine what the best option would be to move forward. Last example I'll go through is one that refers to acute myeloid leukemia. And so this type of disease has many different mutations and many different prognostic factors based on that. So what I mean by that is it helps us determine what type of cancer it is and how aggressive it is, and therefore how aggressive we need to treat it. And so as you can see here in this graphic, the two types of kind of categories are we look at patients who could handle intensive care therapy or want intensive therapy, and then those who do not. So based on that, for the purposes of today, we will just be focusing on looking at one of the mutations in the red box called the FLT3 mutation. So if it is found based on the genetic testing that we do that the type of leukemia has a FLT3 mutation, what we would do would be we would add an agent to the standard chemotherapy that we would typically give our patients without that mutation. And that would be because we know that the leukemia has the mutation, so we want to target it the best that we can. And as you can see here, an example that we would use would be midostaurin. And then if the patient is not able to tolerate intensive chemotherapy, we can also use a medication called venetoclax that my colleague Taylor explained earlier. An additional therapy option may include gilteritinib as well. So overall, our summary and key points for today. So improved diagnostics and testing assays really allow for more individualized patient information. And so that helps us be able to make the treatment of our patients more individualized. Secondly, guidelines are evolving to standardize precision medicine with additional studies that are in progress as well. Thirdly, many different types of targeted therapies, as many of which we have discussed today, have been developed in the past decade. And then lastly, these individualized and targeted therapies have improved survival for many patients with cancer with decreased toxicities compared to our standard chemotherapy, although those are also patient specific. So overall, the more personalized the treatment, we see the better the outcomes. And with that, thank you very much, and we'll take any questions at this time.
Hi, Claire. I do have a couple questions in the chat box. I'm going to read these out to you, and then if you wouldn't mind just staying on camera and answering these. They're kind of all over the place, so I'm going to start with the ones that were from earlier in the presentation. And the question is, if you're having side effects or symptoms, does it mean the treatment is working, or vice versa? If you don't have a lot of side effects, does it mean it's not working as well?
Yeah, that's a good question. So I will answer that by saying, if you don't have any side effects.
Can you speak up a little bit? We can't hear you very well. Sorry.
Yeah, no, that's okay. Can you hear me?
Yes, much better.
Yeah, so I will just say, starting off, if the patient is not experiencing any side effects, that does not mean that the therapy is not working. Like I said earlier, a lot of these different regimens affect people differently. So some patients won't have any sort of nausea, while another patient could have a lot of nausea. I will say there are probably some studies that are ongoing to see if, per se, with our immunotherapies, if patients are having side effects, if that means that they are responding better to these therapies than someone that was not having a side effect, but this is not proven yet.
I'm actually going to combine two of the questions here. They're both really good questions, and they're kind of related. When is the ideal time to make a plan, a precision medicine plan, at the onset of treatment when you're diagnosed, or after recurrence? And in that same light, would you ever repeat the biopsies, or once you test, does the test say the same throughout?
That's a great question. I would say, number one, it's going to depend on your cancer type, but I would say for the most part, we're going to be determining those things at diagnosis. So at the beginning, when we're getting that tissue biopsy and determining what type of cancer you would have, we're also going to be looking for those targetable mutations. If you do have recurrence, we're likely going to be looking for it at that time as well. There are certain mutations that can kind of pop up over time, and your mutation status can change over time as well. So it's important for us to kind of look at those things throughout your treatment. So at that initial diagnosis, and then if you have recurrence, and then also if you have progression of the disease or the disease is getting worse, we may also look at it at that time as well.
And a follow-up question is, what if there's not very much data for a certain type of cancer? Would you still test?
That's a good question. So every different type of cancer is going to have different mutations that we're looking for. And there are certain cancers that have a lot of mutations with a lot of associated medications that we can potentially use. So for example, that pie chart that Claire showed with non-small cell lung cancer, there's a bunch of different mutations that we can be looking for and that we can potentially use medications for. There are other disease states that have less mutations associated with them, but I would say sometimes we are still looking because even if there's one or two medications that we could potentially use, it's worth knowing about.
This is an interesting question. You might want to defer this to Brittany, but let me, or it might be better explained once Brittany does her presentation, but it said, could you explain the difference between somatic testing with NGS versus somatic testing done prior to the liquid biopsy?
I think we should let Brittany answer that one.
Okay, we'll let Brittany answer that one. I do have one other question. When or why would you give chemo and a targeted therapy? If you knew there was a mutation and you could treat it with targeted therapy, why do some of the regimens have both in the regimen?
Yeah, That's a good question as well. So again, this one depends on the cancer type specifically, but I would say that most often you would see a targeted therapy with chemotherapy based on how it was studied and the outcomes that they found how it was studied. Occasionally, you'll see just the targeted therapy at the end of the chemotherapy or even just alone. Again, that depends a little bit more on the type of cancer and their specific mutation status, but I think you could see it multiple ways. And the reason for that is because of how it was studied and with the good outcomes.
Okay, we're going to end your session with a very topical question. Have you seen supply chain issues and back orders on specific medications related to the pandemic?
Yeah, I think there have been a lot of supply chain issues kind of throughout the pandemic with all medications, not just oncology medications, but all medications and, some medical supplies as well. So that's definitely something that we have to work through. Especially as pharmacists, we're going to be managing our kind of inventory for those medications. We're going to be looking at using the supply that we have in the most effective way. So trying to use, like full vials of medication and not wasting any of that medication. So yeah, definitely that's something that we've had to work through throughout the pandemic.
Challenges for all of us. Well, thank you all very much. We appreciate our pharmacists coming to be with the program today.